Hello everyone, my name is Meena Ramchandani. I'm an infectious disease physician at the University of Washington in Seattle. This podcast is dedicated to an STD literature review for healthcare professionals who are interested in remaining up to date on the diagnosis, management, and prevention of STDs. For this episode, we are going to review a few more abstracts presented at the STI and HIV 2023 World Congress that was held in July in Chicago. I'd like to focus on the topic of pharyngeal gonorrhea, which is a hot topic in the STI world, and present some updates from the conference. Please refer to our website for details on the presenters and title of each abstract in the session. These are a few abstracts I selected to share in this episode. There are 2 oral abstracts, which I'll spend a little bit more time on, and then I'll briefly cover 2 poster sessions on this topic as well. The first oral abstract to discuss was presented by Dr. Quilter and titled Routine Pharyngeal Gonorrhea Test of Cure. Does it detect treatment failures? In this study, 4 health departments in different U.S. cities were funded to implement and assess pharyngeal gonorrhea test of cure as a strategy to identify and prevent the spread of antibiotic-resistant gonorrhea. The study was conducted between May of 2021 and July of 2022. There were greater than 1,900 pharyngeal gonorrhea cases diagnosed across the participating STI clinics. And of the roughly 1,800 cases with documented treatment, 97% received the recommended treatment per the CDC 2021 STI treatment guidelines. Around 830 infections had a test of cure performed, and 46% had a test of cure response rate. And the authors defined the pharyngeal gonorrhea test of cure response rate as the number of patients that had a test of cure performed after treatment administration over the total number of patients treated for pharyngeal gonorrhea at the clinical site. And the response rate differed by site, anywhere from 32% to 68% at different participating STI clinics. They found that the median time from pharyngeal test of cure to treatment initiation was 14 days. They also found that 97% of test of cures were a NAT test only. The rest were NAT plus culture. NAT stands for Nucleic Acid Amplification Test. Among those with a test of cure performed, around 830 persons, 94% were negative, 5% were positive, and 1% were indeterminate. Among the positive test of cure cases, which was 39 persons, 51% had no culture done, 15% were culture positive, and 33% were culture negative. Based on this information and a detailed chart history, it was thought for the 39 cases who had test of cure positivity, 33% or 13 persons were a false positive based on their NAT and culture results. 18% or 7 persons were treatment failure, and 33% or 13 persons were reinfection. Another 6 persons were lost to follow-up. 5 of the 7 cases that were treatment failures received retreatment, and all eventually had negative NATs at further follow-up testing. So this is an important topic because pharyngeal gonorrhea may facilitate acquisition or development of antibiotic resistance for Neisseria gonorrhea. The thought is that there might be genetic reassortment and plasmid uptake of resistance genes between Neisseria gonorrhea as well as other Neisseria species in the oropharynx. There also might be poor bioavailability of antibiotics at the pharynx, and that's why these infections might be more difficult to treat. Now, ceftriaxone is the only antibiotic to reliably eradicate gonorrhea at the pharynx per the CDC 2021 STI treatment guidelines. And even though this antibiotic usually works well, there have been rare reported Neisseria gonorrhea treatment failures with ceftriaxone, and these failures most often occurred at the oropharynx. This abstract evaluated the yield of routine pharyngeal gonorrhea test of cure to detect treatment failures. The authors found that among 4 STI clinics, the test of cure response rate for pharyngeal gonorrhea cases was low at 46% and varied by site. Now, while 5% of the test of cures were positive, the authors also found that the majority of these were actually due to reinfections or false positive tests on a deep chart review. They found that ceftriaxone failure was rare, less than 1%, and there were no cases of cephalosporin-resistant gonorrhea identified, which is reassuring. The second oral abstract to discuss was presented by Dr. Visser, and it was titled Within-Person Differences in Neisseria Gonorrhea Antimicrobial Resistance Patterns between anatomic locations. The authors took advantage of a unique opportunity to get within-person data on gonorrhea infections through the Dutch gonococcal resistance antimicrobial surveillance program. They looked at data from the surveillance program between 2016 and 2022 and evaluated cohorts of MSM, or men who have sex with men, and women with gonorrhea cultures that had MIC values to ceftriaxone available for 2 or more anatomic locations. Now let's take a step back and describe what an MIC value is. MIC stands for the minimum inhibitory concentration, and it's the lowest concentration of a particular antibiotic at which bacterial growth is completely inhibited. Now, meeting this criteria, they were able to evaluate 877 MSM and 288 women, so a total of 951 persons. They found that in about 20% of individuals, the MICs of Neisseria gonorrhea to ceftriaxone differed between anatomic locations. This is a big deal. What it suggests is that bacterial growth of this organism is inhibited at different concentrations of ceftriaxone in different anatomic locations within the same person. Different MIC values were more common in MSM than in women, and they also found that Neisseria gonorrhea MICs to ceftriaxone were more often higher in the pharyngeal location than the urogenital location for both MSM and women. In summary, pharyngeal gonorrhea infections are thought to play an important role in antimicrobial resistance, and the study assessed within in-person patterns to improve our understanding of the role different anatomic locations play in gonococcal antimicrobial resistance. When they looked at risk behavior, the authors did not find that there were any behaviors associated with increased risk of STIs that were associated with differing MIC values. The next abstract to discuss was a poster that was presented by Dr. Wolfs and is titled High Bacterial Load in Neisseria gonorrhea and Chlamydia trachomatis co-infections Does Not Influence Symptoms. Between 2012 and 2021, they evaluated over 3,000 patients with Neisseria gonorrhea who attended an STI clinic in the Netherlands. They found that Neisseria gonorrhea bacterial load was comparable in those individuals who were either Chlamydia trachomatis positive or negative in oropharyngeal samples, as well as the urine. But they did find that the Neisseria gonorrhea bacterial load was higher in Chlamydia positive vaginal samples in women and anorectal samples in men. Symptoms they found were just as frequent in those who were co-infected with chlamydia compared to those who were not for all sample types. This group looked at Neisseria gonorrhea and Chlamydia trachomatis co-infections in individuals with regards to symptoms and bacterial loads. Co-infections are reported in about 40% in higher risk groups. And what they found is that anorectal co-infections had higher Neisseria gonorrhea bacterial loads, but the bacterial loads were similar in urogenital and oropharyngeal samples for those persons who were chlamydia positive or negative. The next poster to discuss was presented by Dr. Melendez and is titled Oropharyngeal Gonorrhea Among Men with Symptomatic Urethritis Seeking Treatment at Government Health Centers in Kampala, Uganda. The authors of this study evaluated 200 men with urethritis seeking care between 2021 and 2022. They found that 5.5% or 11 patients had Neisseria gonorrhea infection in both the urogenital and pharyngeal locations, while 53% or 106 patients had Neisseria gonorrhea infection of the urogenital tract only in this cohort. They did not assess how many patients had infection of the pharyngeal site alone. All Neisseria gonorrhea isolates were resistant to ciprofloxacin, penicillin, and tetracycline. But they also found that all isolates were susceptible to the extended spectrum cephalosporins. The authors found that 90% of the urogenital and pharyngeal Neisseria gonorrhea isolates had the same antimicrobial susceptibility profile. There are limited data on pharyngeal Neisseria gonorrhea infections, especially in low and middle income countries, but this information is important as pharyngeal Neisseria gonorrhea infections are thought to be a source of sustained gonorrhea transmission, and possibly, as we discussed, play a role in the emergence of antimicrobial resistance for this organism. This study found high rates of antimicrobial resistance in urogenital and pharyngeal gonorrhea in men in Kampala, Uganda, although the number of persons with pharyngeal infection was low. To conclude, I'd like to summarize some key points from the session. Test of cure response rate for pharyngeal gonorrhea cases is low in STI clinics, and the majority of positive test of cure were due to reinfections or false positive tests. The MICs of Neisseria gonorrhea to ceftriaxone differs between anatomic locations in some individuals and are more often higher in the pharyngeal location than the urogenital location for both MSM and women. Neisseria gonorrhea bacterial load was higher in chlamydia-positive vaginal samples in women and anorectal samples in men, but not in oropharyngeal samples. Lastly, there are high rates of antimicrobial resistance in urogenital and pharyngeal gonorrhea in men in Kampala, Uganda. This podcast is brought to you by the National STD Curriculum, the University of Washington STD Prevention Training Center, and is funded by the Centers for Disease Control and Prevention. Transcripts and references for this podcast series can be found on our website, the National STD Curriculum, at www.std.uw.edu. Thank you for listening and have a wonderful day.